Hello and welcome back to Brain Pods. I am here with Dr. Nelson. Say hi.
Hello.
As you know, Dr. Nelson, from numerous areas of your undergraduate education, from HHD5 to the psychiatry clerkship, which is tandemed with the clerkship we're doing right now. And so I greatly appreciate Kaz being here today to provide us a little bit of integration in terms of neurobiology, neuropharmacology, and how we use these in psychiatry. And I want you to know we just spent about 10 minutes where Kaz was like, I don't think they need to know a lot of this stuff. And I said, you know what? I want you to tell it on the screen so that just get everybody kind of a new perspective on kind of how to look at this. That sound good?
Yeah, we want this to be very practical. You're wondering how do we understand these receptors and pharmacologic agents enough
Yep.
to be able to
Yep.
help people, and that's the point of this.
I'm going to make a case that you need to know about muscarinic receptors. If I do nothing else than that, that's what we're going to do. All right. Okay. Let's get rolling right now. So here we are on volume 2. We just did a review of neuroanatomy with the excellent Dr. Chafee. Let me just start with just a little review of a fascinating condition that occurred about World War I, after World War I, of encephalitis lethargica. Kaz, you obviously have heard of you saw the movie Awakenings.
Yes.
With Robert De Niro and the late great Robin Williams. Which was a little bit of a post-encephalitic Parkinsonism, and those individuals responded to levodopa. Of course, it's a Oliver Sacks story. But this was the condition, and the reason why I bring it up is that it was because of this condition. Von Akamono, that's him right there at the University of Vienna, did some lesion experiments which first noted that with a lesion here with the arrow left people very sleepy.
That's the brainstem there, right?
Right, that's the brain. Thank
Yep.
you. Yes, this is the brainstem here. This is the reticular activating system. By lesioning that, they became quite sleepy. A few of them, about 20% of them, had a lesion farther forward here, which resulted in insomnia. But this was the first recognition that the reticular activating system actually helped maintain some degree of alertness. Later on, this was discovered in more detail with some feline lesion experiments, where it was quite interesting. So all they were doing were this was after World War II. They were just doing some lesion experiments in the reticular system, mainly looking at when you would stimulate different regions of the reticular system, what would happen to axial tone, and the cats were anesthetized, right?
The cats fall down?
Well, they were anesthetized, and they had the EEG on their head, just looking to confirm that they were asleep, anesthetized, and they stimulate the reticular activating system, and guess what happened? They woke up.
Out of the anesthesia.
Out of the anesthesia, yeah. So that was where the reticular activating system comes from. That story is not particularly important, other than that is how we initially discovered the reticular activating system. So, and the structure of what the majority of this podcast is going to be about is to walk through the various neurotransmitters, and we're going to keep our focus on neurotransmitters, their metabolism, their uptake, in particular the effect on pharmacology. So neuropharmacology, psychiatric pharmacology. So as we go through these neurotransmitters, this one little table is quite helpful because it lays down the different states, wakefulness, non-REM sleep, or REM sleep, and what these different neurotransmitters are doing. So acetylcholine monoamines, that's your dopamine, your norepinephrine, others, as well as orexin. They're all quite active during wakefulness. During non-REM sleep, it's only the monoamines that are active. They're less active than they are when they are awake. And then acetylcholine is quite active during REM sleep. All right, so these are all the neurotransmitters we're going to go over. We're going to start with acetylcholine, and then we're going to work our way through them. All right, so as we just went over with the table, acetylcholine promotes wakefulness and REM sleep. It is secreted from two brain regions, one of which is here in the pons, another of which is here in the basal forebrain. It's the major transmitter of the neurotransmitter of the peripheral nervous system. Norepinephrine is a very, very distant second. This slide, Dr. Nelson and I were talking about quite a bit before we got started, which is we don't want to give too much of an impression that it's critical to walk and know every step here along the course. Although I do think there's utility in recognizing that in general a neurotransmitter reaches the end of the presynaptic terminal, usually
Of a nerve cell.
Of a nerve cell. Thank you very much. Yeah. So
When you say it's
yeah.
secreted in the
Yep.
brain, you're talking about the little ends of nerve cells are actually
yeah.
spitting out this substance.
Right. Yeah. So the presynaptic neuron, postsynaptic neuron, and how does the dopamine or serotonin or however get to the point where it's functioning? So it's metabolized through whatever step is important, and then it's put into a synaptic vesicle, and then it's secreted. It affects the receptors. It's reuptaked.
And then we use this term projects, depending on the shape of that nerve cell, that could have influences in another part of the brain.
Yes. Exactly.
Because traveled along the line of brain communication.
Exactly. And so this is just laying down the key steps of acetylcholine, but you can think of this a very similar slide for norepinephrine or dopamine, histamine, whichever else you're talking about. And so in terms of all of this, the key steps I want you to think about for acetylcholine is that the release of which involves some pretty important proteins, in particular SNARE and SNAP, because they're involved as part of the mechanism of action of botulinum. We'll get into binding of acetylcholine later, and then we're going to get into the metabolism of acetylcholine via acetylcholinesterase. So for all of those, I would just ask you to think about those. In terms of the receptors, here's our two types of receptors, muscarinic and nicotinic receptors.
This is on that receiving nerve cell,
right,
on the other side of the synapse.
Brilliant, thank you,
Okay.
Cass. Yeah, so this is the
Maybe not brilliant. I'm just trying to follow along.
No, that's the postsynaptic terminal has these receptors on it. Muscarinic receptors. So the majority of the brain acetylcholine receptors are muscarinic, and they are also the postganglionic parasympathetic nervous system receptors. Conversely, the nicotinic receptors are mainly just at the neuromuscular junction.
In the body.
In the body, at the level of the muscles. At the level of the muscles. There are a few, not many, in the central nervous system. We know that there are some in the central nervous system because see nicotine addiction. So when you think of smoking, I often think of smoking as an addictive behavior, and when I think of addictive behavior, I tend to think of dopamine.
Yeah.
But we know that I think of dopamine and smoking as being a more downstream effect, but its acetylcholine effect is on the nicotinic receptor.
So potentially, so is the nicotinic receptor stimulated by nicotine or by acetylcholine?
Yeah. So the nicotine receptor in general in your body right now, for those of you who are not smoking cigarettes, that is being activated by acetylcholine.
Uh-huh.
However, when people ingest nicotine for however they take it, that is activating nicotinic receptors.
Directly.
Directly, yeah, it's a direct agonist.
Mm-hmm.
Yeah.
And potentially those nerves that go on to be stimulated at the receptor maybe then interact with areas of the brain that interact with dopamine down the line.
Absolutely.
That's what you're saying.
Yeah, that's
it's
what.
Kind of a downstream.
It's a
effect.
downstream. It's a downstream. Like a lot of things. Like a lot of things are downstream effects. Okay. Next. So when we think about the pharmacology of acetylcholine, think of it in very, very basic terms of either impaired release of acetylcholine from that presynaptic neuron into the synaptic cleft, or overactive release. So as we talked about those SNARE and SNAP proteins, which help the presynaptic vesicle fuse into the synaptic cleft, it interferes with these critical proteins, and so that your acetylcholine is not able to be released, and you end up with paralysis. Conversely, you can have overactive release of acetylcholine, and that's black widow spider toxin, which I have never seen. I don't expect to see.
It could kill you.
It could kill you. It will kill you. Yes, it can kill you. So that's release. Now we're talking about pharmacology on the receptors themselves, and it depends upon what receptor we're talking about. So pilocarpine is an eye drop, and it constricts the pupil. So the pupil dilates with sympathetic activity, norepinephrine, and it constricts with parasympathetic activity, acetylcholine. So pilocarpine is a muscarinic agonist, and it constricts the pupil. Antagonists are direct blocking. Antagonists of the receptors include organophosphate poisoning, as well as scopolamine, which treats vertigo. Agonists, getting at nicotine receptor agonists include the obvious, as we talked about before, which is nicotine. And then antagonists used as paralytics and anesthesia include non-depolarizing paralytics, the curare agents, and then depolarizing antagonists, meaning, and what that means is they activate the postsynaptic receptor, and then they keep it activated so that it cannot be reactivated anymore.
Oh, it kind of stimulates and blocks?
It stimulates and holds it open. It holds the signal open so that you can't keep contracting. They both end up with paralysis, but work via very different mechanism. All right. Here's acetylcholinesterase inhibitors are very important in neurology. And they work by blocking the metabolism of acetylcholine, because acetylcholinesterase breaks down acetylcholine, and so if you inhibit acetylcholinesterase, you end up with a lot more acetylcholine in the cleft. And if these are non-irreversible, so another way to say that is just say reversible, right? If they're reversible, they tend to be medications. If they're irreversible, they're poisons. And so reversible ones, non-irreversible ones, include pyridostigmine, which is used for myasthenia, and you can see that here with a little bit of ptosis, which is a classic manifestation of myasthenia, as well as Alzheimer's is related, at least in part, some of the cognitive impairment is related to a failure of activation of acetylcholine to the forebrain, and so by boosting acetylcholine's effect through an acetylcholinesterase inhibitor, that can help improve concentration, a little bit of memory. It has not worked. It was thought when donepezil was originally brought out that this was going to be as groundbreaking for Alzheimer's disease management as levodopa was for Parkinson's disease. Unfortunately,
that's not borne out.
That has clearly not borne out. Irreversible acetylcholinesterase inhibitors, however, result in poisoning. This picture on the left was the poisoning of Kim Jong-nam, Kim Jong, the brother of the leader of North Korea, and this is sarin gas exposure in Syria. These by irreversibly inhibiting acetylcholinesterase, you end up with this massive muscarinic.
Is that similar to black widow spider poisoning then?
Well, it would be, yeah. I mean, it would be. It works by a different mechanism.
The same way.
Yeah. So botulinum toxin. I'm sorry. Black widow spider toxin just shoves all of the acetylcholine into the cleft. It's already getting into the cleft naturally, but it just can't be metabolized out.
So different mechanism, but same result, which is bad.
Bingo. Yeah. And with acetylcholine side effects, which is sludge, which is salivation, lacrimation, excessive urination, diarrhea, GI distress, and emesis, which is just massive parasympathetic nervous system overactivity. So what do you do in these situations? So these toxins are inhaled. They can be absorbed through the skin. And so And care workers who come to help and aid in these situations can often end up getting poisoned themselves. So clothes need to be removed. They need to be washed off. They need to have respiratory support because they're now paralyzed, right?
Yeah.
Because their muscles are no longer working. And then antidotes. So atropine is a muscarinic antagonist, and so it blocks some of the overactivity. However, as we talked about before, muscarinic receptors are primarily just in the brain, so that's not going to help out the weakness.
Your paralysis.
So they still need to have respiratory support in order to survive. Pralidoxime also helps regenerate acetylcholine receptors. All right. So that's when you just think of
I never think of acetylcholine.
You know, I mean, well, I think that's no, that's I think
in psychiatry.
I think that's useful. I mean, so when you think of, we're going to get to them later. So what neurotransmitters do you really think about in psychiatry?
Dopamine, serotonin.
Those are the big ones.
Those are the big
Those
ones.
are the biggies.
Yep.
Right.
GABA.
We like GABA.
Yeah, but we do think about the vagal nervous system a lot and how to stimulate the vagal nervous system. So we don't think about it in terms of acetylcholine, but we do want to take advantage of the parasympathetic nervous system to combat some of the effects of anxiety and trauma that are mediated by the sympathetic nervous system.
Calms things down a little.
Yeah, we're usually trying to up the acetylcholine game, I guess, through stimulation of the vagal nerve. But I don't ever think about it in terms of the neurotransmitter itself, primarily because it's not like I'm giving a medicine to enhance the vagal nervous system.
Right.
I'm using techniques to
You're
stimulate
just stimulating it. Got it. That's great. Thank you. All right. So on to certainly we think about catecholamines.
Mm-hmm.
All right. Again, so here is a figure that you will often see. This talks about all catecholamine synthesis, so not only dopamine, but norepinephrine and epinephrine, because it's all part of the same synthetic pathways. What are the clinically relevant steps I think you should know? Rate limiting step is tyrosine hydroxylase. And then metabolism is through catechol methyltransferase and monoamine oxidase, both of which are targets for pharmacological intervention in a variety of conditions, which we will get to. So there's a lot of things that happen in all of these steps. What I want you to know more than anything, I think, is that iron is a cofactor. And that's relevant because a lack of dopamine production can lead to restless leg syndrome. And restless leg syndrome is very, very common in otherwise healthy premenopausal women who are iron deficient. It's very common in women who are already relatively iron deficient and then become pregnant. There's this massive expansion of hemoglobin which just sucks up all available iron, and then restless leg syndrome really becomes quite profound. And all this is just showing tyrosine hydroxylase, and I'm just circling here that iron is a cofactor. Okay, now let's talk about a couple of catecholamines in particular, which is we'll start with dopamine. Psychiatry's favorite neurotransmitter, or is it just it's a child like serotonin? It's a split love with serotonin.
If you are a psychosis or schizophrenia expert, then you're thinking a lot about dopamine. Got
it. All right. Well, so I have a slide up here of where dopamine, as a psychiatrist, when you think about, or a patient asks you, well, where is my dopamine that you're trying to manipulate? How would you explain that to them?
I would say, unfortunately, it's all over, so that it's very difficult to target when we're trying to treat psychosis.
Got it. Okay, which goes well with this slide, which is that we're just reminded that dopamine is the most prominent monoamine in the brain, 3 to 4 more times dopamine than there is norepinephrine. It has a wake-promoting pattern, so very robust when we're awake, should be down when we are sleeping. What are the key steps? Again, tyrosine hydroxylase is the key rate-limiting step. Later, when we give people who have Parkinson's disease, for example, we give them L-DOPA, levodopa. We're not giving them dopamine directly, we're giving them L-DOPA. A precursor, which is then decarboxylated by dopa decarboxylase, which becomes dopamine. Okay, And again, then the key metabolic steps include COMT and MAO. We do have a little bit on receptors. There's a lot of dopamine receptors, not as many as serotonin, but I'll try to simplify those for you. So here are the receptors. So I think whenever I review this CAS, usually there's like 5 dopamine receptor classes, and then after staring at this for about 10 minutes, I kind of lose interest and kind of move on. But I do think that in general they're kind of classed as either D1 activating or D2 inhibiting, and then depending upon the later transmitters, they're said, well, it's a D4 receptor, but it's like a D1 or D2. Does that make sense?
Yeah, we mainly worry about the D2.
The D2, right. So D2s are inhibiting, D1s are activating. Let's talk a little bit about Parkinson's disease. So Parkinson's disease is a lack of dopamine that's coming from the substantia nigra. So it fails to provide innervation up to that extrapyramidal circuit, which then overall results in a decrease in motor activity from the globus pallidus and thalamus up into the cortex. Your motor circuit, your pyramidal motor circuit from your motor cortex down to your spinal cord is fine, but you just don't have enough generation of motor activity, so everything is down, right? They're bradykinetic, they're slow, they walk slow, they eat slow, everything is just kind of slows down. That's due to a loss of dopamine, which I think this is a good chance to bring in, classic antipsychotic medications, because I love the story.
Yeah.
I love the story and I'll tell you my understanding of the story. You tell me what I get wrong, but my understanding is that the discovery of chlorprothorazine, which was the first typical psychotic agent, was originally developed not for mental health purposes, but instead as a antiemetic, I believe. Particularly, I think in post-op, post-anesthesia. The old anesthesias used to cause a tremendous amount of nausea, and so they came up with this agent, blocks dopamine, which incidentally does help with emesis. And so they gave this to all of the post-operative patients, and the coolest thing happened was that everybody was just chilled out, which was absolutely one of the greatest discoveries of the 20th century in neuroscience. It revolutionized how we treat psychotic disorders. It allowed for the deinstitutionalization of just a tremendous number of state mental health facilities.
Yeah, our treatments for psychosis before that point left a lot to be desired.
Right. I mean, it wasn't because we were cruel. It was because that was all we. I mean, people were chained to a wall because that was the only thing that was often the only thing that could be done for them. This completely changed and revolutionized that. A very, compared to where we were, now when we think of Thorazine and these other things, we just think of all the bad downsides to them. We don't think about how it, kind of helped change, change much of what we do in a very good way. But one of the things that Thorazine does is it leads to a Parkinsonism, right? It leads to the bradykinesia, masked facies, stooped posture, nicely described here. So Parkinsonism is from decreased dopamine pathology, either from the inherent striatal production of dopamine or from antipsychotic medications.
Which block dopamine receptors.
Right, which block primarily their mechanism for treating psychotic disorders, I think, is by D2 blockade, right? They also have some degree of D1 blockade as well, which I think leads to the Parkinsonism.
If you have someone with Parkinsonism and psychosis,
yes.
you're really in trouble.
Yes.
Because
right? How do you treat that? What is the balance? And this is not an uncommon problem. I mean, I bet it's exactly the opposite for you. But what we get counseled for when we come over here to psychiatry is, okay, someone with a thought disorder, long-standing on antipsychotic medications, has a tremor. Do they have real is there some real Parkinson's disease pathology underneath the drug-induced Parkinsonism, right? I mean, And there's a few other tips you can look for that. Like one thing I'll ask for is, do they have other evidence of neurodegeneration besides that? Can they smell? Do they have constipation? Do they have REM sleep behavior disorder, which can be a serotonergic problem? But and conversely, a lot of people who get Parkinson's disease, other Lewy body pathology can end up with hallucinations.
Right.
And sometimes we just don't figure this out until you try treating them with conventional agents, and then when it doesn't work, we say, well, I guess that's you kind of eliminate different types of pathology that way.
This is where you, as a psychiatrist, grab your neurologist, go arm in arm, and you duke it out. How much antipsychotic are we going to give to treat the psychosis?
Right.
How are we going to adjust the Parkinson's treatment? How do we balance that just right so they have, maybe some psychosis and some movement side effects, but it's optimized where it's not too much of one or the other, and they can function easier.
Got it. All right. All right, so let's talk about Parkinson's disease treatment. This is bread and butter neurology. How do we give more dopamine? And three main different ways. You either increase the presynaptic dopamine production. That's by giving this L-DOPA here that we talked about. You can do direct D1 activation of the receptors. That's with the pramipexols, the ropinirolls.
Cocaine, in theory?
Cocaine is mainly dopamine and norepinephrine reuptake inhibitor. Is that right?
I don't remember.
Okay, I think we'll get to that in a second. But yes, I suppose, Dr. Nelson.
Would cocaine treat Parkinson's? That's my question.
Yes, you certainly would get increased motor activity for a short period of time. So yes. and then you can prolong dopamine action through by decreasing its metabolism, and we'll just go through here this quickly. So there's the levodopa carbidopa, there's pramipexole ropinirol, there's COMT and MAO inhibitors. Okay, so what do you do when you have Parkinsonism from antipsychotic medications? So you have someone who clearly needs to be on an antipsychotic.
Mm-hmm.
They're now developing Parkinsonism with conventional. And would you just list off the big conventional typical antipsychotics?
Yeah, so we're talking about first generation antipsychotics. This could be Haldol, Thorazine.
Right.
Any of those.
Okay, all right. So now that was working. Parkinsonian side effects are too much of a. What do you do?
What you could do is, if the medication's working really well, sometimes we'll use antihistamine medications like benztropine or something like that to try to help with some of the extrapyramidal side effects.
Okay.
But if we really feel like they need a change, you could switch to a second generation antipsychotic, which have other side effects, but a little bit less of the extrapyramidal side effects because of the serotonin agonism, we think.
Okay.
And that are inherent in second generation.
And when you say those second generation, just list off what are the big?
Olanzapine,
quetiapine, which is Seroquel.
Risperidol.
Yeah.
Aripiprazole, which both stimulates and blocks the D2 receptor. And works as an antipsychotic.
This is why we don't want to get too tied up into specific. and then to add a layer of complexity to it, it's dose effect, right? Yeah. So like you give a certain dose, and these do exactly what you are wanting them to do, and then you give them more, and then all things are off the table in terms of the pharmacology.
Yep.
All right. So we're now moving past dopamine, and we're now into norepinephrine. This is in neurology we do not have too much. This is not a big neurotransmitter that we work with that much. It has, again, the same monoamine pattern of secretion we talked about before. It promotes arousal in response to stress.
Yeah.
And then, again, same synthesis, same main rate-limiting step in tyrosine hydroxylase. We'll talk about vesicle release, binding, and reuptake in a couple later slides, but then also remember metabolism through COMT and MAO. Vesicle release. That's the target of amphetamine. So methamphetamine just pushes norepinephrine as well as dopamine into the synaptic cleft. That's where you end up with that hyperadrenergic state. So in general, when I think of norepinephrine pharmacology in clinical neurosciences, I think of it as an effect to essentially decrease hyperadrenergic states, whether or not they're tremor, anxiety, PTSD, amphetamines, alcohol withdrawal. That should say alcohol withdrawal and amphetamines, not the other way around. And this is done through all of the agents that you've heard of before, whether or not it's beta blockade with the beta blockers, alpha-1 blockade, which is prazosin, which is commonly used in post-traumatic stress disorder, and then alpha-2 agonists, which is confusing but they're essentially autoinhibitors, and that's clonidine. And so now we're starting to get into reuptake inhibitors, which we're really going to get into when we talk about serotonin. But oftentimes these reuptake inhibitors often have other effects on other neurotransmitters, including norepinephrine and dopamine. Is that when you think of tricyclics, besides the effect on serotonin, what else do you think about?
Oh, yeah, they have. I just think of them as having a lot of different receptor actions, sort of like, that's not the right term is not dirty, but I mean, you kind of think of it as they hit a lot of receptors.
I've heard.
I don't like saying it's a dirty map.
I have heard. My good friend and colleague Carlos Schenk calls them promiscuous.
Yes.
So we envision that we know exactly what receptors that they're going at. We actually don't know nearly as much as we pretend, especially with tricyclics. And just a couple of examples of amitriptyline, nortriptyline.
They're highly toxic in the case of overdose.
Mainly cardiac, right? Is it cardiac arrhythmias?
They'll stop your heart if you
Yes.
just take a little more than you're supposed to. So we don't prescribe those to people who are at risk of suicide.
Okay, so speaking of cocaine,
Yeah.
so this is cocaine is a fantastically potent antidepressant agent. However, with the withdrawal and the rebound and everything else, it destroys lives clearly. All right. Now moving on from norepinephrine. Now we're still in the monoamines, but now we're to psychiatry's equally favorite twin, which is serotonin. So serotonin is secreted from the Raphe nucleus. So we're getting an idea that all of this is coming from the brainstem and innervating all sorts of different regions in the cortex. Again, the same monoamine pattern of secretion, robust during wakefulness, a little less during REM sleep, a little less during non-REM sleep, and then nothing during REM sleep. I gave up on trying to understand serotonin receptors a long time ago.
There's a lot of them.
There's a
lot
lot
of subsets of
Right.
receptors.
Right. That being said, serotonin has, it equally revolutionized the management of mood disorders as anti-dopaminergic agents revolutionize the management of thought disorders. Fair to say?
Yes.
Yeah. But then, is there any particular receptors you think about that are particularly relevant of this huge mass, or
5-HT2?
Is that what do you like about that one? I don't
know.
I like my own. I couldn't tell you why.
I think that's the biggie.
The biggie. Okay,
when it comes to
5-HT2.
what we do.
For the one receptor, if you're going to know any of them, that would be the one to know.
Yeah.
All right. Fair enough. And so again, keeping with the theme here, rate limiting step is tryptophan hydroxylase, which is again iron. Iron is a cofactor in that one as well. The binding is confusion. Reuptake we'll get to on later slides. And again, metabolism is monoamine oxidase. Remember, no catechol-O-methyltransferase because it's not a catecholamine. That doesn't metabolize serotonin, but MAOs do. All right. So again, I just mentioned, tryptophan hydroxylase. Hydroxylizing the amino acid iron is a cofactor. Is actually I never thought about this until this moment. Is that we look for iron deficiency all the time in RLS. And in depression, is that something that's looked into, or?
Well, we think about it in terms of like anemia. If someone's anemic or iron deficient, that clearly results in difficulty with mood and functioning. But I don't know that we approach it in the way you're describing, but it's an interesting idea.
Interesting. Okay. All right. I'll just leave it at that. And also, just adding to a layer of complexity is how do you actually measure iron?
Right.
Extremely difficult, because what we want to know is what is your iron in your brain, not your iron here. And then not only if you measure it here, are you measuring the floating iron? Are you measured when it's bound up? It's very difficult short of a brain biopsy, which most of our patients don't let us do.
Right. Risk benefit.
Right. Okay. So serotonin receptors, 5H, you've heard it from Dr. Nelson, 5-HT2, I looked up before I put this slide together over 100 different agents with varying degree of affinity. You know, short of doing a postdoc in any of these, I wouldn't bother.
It's outside of the scope of this course, certainly.
Right. That being said, so when I think of conventional antidepressant medications, I tend to think of anyway, just serotonin reuptake inhibition. There are agents that actually have direct agonist activity on the receptors, probably 5-HT2, but I won't hold anybody to that. Is when you think of these other non-SSRI agents, is that how you think of these, or the mirtazapines, the trazodones? Is it maybe it's not even necessary to really?
I just think of them as having their own sort of independent mechanism of action. I don't necessarily spend a lot of time thinking of what that mechanism of action is, but it's different enough that if somebody's not responding to these other ones, you might get into this other territory. Or they're having trouble sleeping because of the unique mechanism of action of trazodone and mirtazapine, you might go that direction.
They have a little bit of a blockade of the histamine system. Histamine is a very potent stimulant, so if you block that, you're a little bit more sedated. But I think what Dr. Nelson just mentioned there is most important, which is if an SSRI isn't working, instead of going to another SSRI, why don't you maybe do a serotonin agonist? And if they happen to have maybe some insomnia and the sedation might help out with that, all the better. Is that kind of the way you think about it?
We sometimes combine these things too because they have different mechanisms
of
action, if need be.
Which is going to come up to another issue, which we definitely want them to know, which is serotonin syndrome. Ding.
Bad.
All right. Right, and which is something that psychiatrists in particular need to think about. All right, so this is just the reuptake inhibitors. So tricyclics and tetracyclics are reuptake inhibitors, not only of serotonin but also norepinephrine. SSRIs are, as the name would suggest, mainly just serotonin. Here's one question I had for you, Dr. Nelson, which is, and maybe it doesn't matter. You can just say it doesn't matter if it doesn't matter. But when I think of venlafaxine and duloxetine, they say serotonin norepinephrine reuptake inhibitors. Well, why aren't they just tricyclics then? Or is the tricyclics like a name of their structure? And maybe they don't have that three-ring structure. I don't know.
Yes. So if they didn't have the three-ring structure, it wouldn't be a tricyclic.
Yeah.
But I think they mechanistically act a little bit different. I think at a certain dose, it's mainly SSRI, and then you get a little bit higher dose, then it brings in the norepinephrine reuptake inhibition.
Okay.
And I think the tricyclics, like we mentioned before, they have many other they stimulate many other things too.
Yep.
Broader, and this is a little more focused in these regions.
Got it. Okay. All right. So there is a lot of antidepressants work by inhibiting
different combinations of things.
These agents reuptake.
Yeah.
You keep them around in the synaptic cleft longer.
Yeah.
Fair enough.
Yeah.
All right. Good. All right. Okay. Now let's talk about medication management. So we want to look for serotonin syndrome.
Yeah.
Especially if you need to do combination agents. And I don't get into this in this talk, but those individuals with migraines, they sometimes use triptans, which are serotonin agonists. If you combine that with someone who also may have depression, two very common conditions, you get serotonin syndrome.
Yes.
So I have a description of what serotonin syndrome looks like. Can you give me any anecdotes of just kind of how patients sometimes will present?
Very flushed, tremulous, sweaty.
Okay.
It's uncomfortable. They're confused. Maybe they start to lose their senses a little bit, get a little delirious. It's an emergency.
Febrile? Do they become febrile? Maybe some autonomic
there's
symptoms.
some autonomic instability. Yes.
Okay. And I get confused with serotonin syndrome and neuroleptic malignant syndrome.
Yes.
How I separate the two of them is, remember that dopamine has a motor component, and because of that, they're often rigid.
Yes.
Like a lead pipe, kind of rigid.
Yeah, and unfortunately, they're both still clinical diagnoses, so you kind of have to look at the pattern of symptoms. But yes, I agree that rigidity,
Yeah.
if you see that, you need to really worry about neuroleptic malignant syndrome, also an emergency.
And this is not just an academic exercise, because people who are really struggling with mental illness often have a lot of combination of dopaminergic blockade and extra serotonin floating around, and the same person can have the same syndrome.
Yeah.
Right. All right. So and also one other thought I have is in neurology. I mean, so it's not unusual for us to get a consult of someone who seizes after being on an activating antidepressant, whether or not that's bupropion or venlafaxine. So the more norepinephrine component they have, which often patients like, because it helps wake them up. They have, I think, less of the sexual side effects than the other antidepressants, but it does lower their seizure threshold.
Yep.
All right. Now moving right along, we're going from norepinephrine and serotonin all the way down to histamine. This will be pretty brief. Histamine is secreted from the tuberomammillary nucleus right here. This is a very potent stimulus.
The thalamus. We're in the...
Oh, yeah, so this is the tuberomammillary nucleus is of the hypothalamus. I consider part of the hypothalamus. Thalamus is over here, hypo below the thalamus is down here. Strong stimulant, and considering the widespread use of antihistamines, diphenhydramine, Benadryl, and that's primarily, the brain primarily works on H1 receptors. H2 receptors, from a neuropsychiatrist perspective, I don't think we really even need to think about. They're mainly GI agents. But as Dr. Nelson was talking about, is several antidepressants have a histaminergic component to them.
Yep.
And they tend to be a little bit more sedating.
Yep.
Okay, so of the tricyclics, it's doxepin. Of the serotonergic agonists, it's mirtazapine and trazodone. Moving on to peptides. So this is just big picture stuff. We're going to talk about opioids. I have a story. This is I'm sure all of you have heard and have had lectures on opioid epidemic. I got to tell you a story, Kaz, on my own experience with this. So I became licensed in the state of Minnesota to practice medicine in early 2006. Okay, and I don't know if we still need to do it, but back then we needed to go down University Avenue to the Board of Medical Practice. You're
Say
familiar.
hello.
You're familiar with this.
Watch a little video. Yeah.
Watch a little video. And this was 2006. So this was it wasn't like we didn't know opioids were a problem back then, but it was the idea that this was going to be a devastating public health concern was not on our radar. And you think about everything you would want to tell someone who's about ready to practice medicine in the state, whether or not it's like, we're glad you're here, we hope you do a good job, try not to kill people, the thousands of different things. Only one thing they told us in terms of clinical management, only one thing, and that was it was the weirdest way they did it. They had this newspaper clipping. And it wasn't even in the state of Minnesota. It was like a newspaper clipping from someplace in New England. And they handed it to all of us in the package we got. And it was about a doctor who lost their license for not prescribing enough opioid analgesia.
I can't believe that.
Well, now, the case itself, you read through the case, it was appalling. It was a woman with metastatic breast cancer to vertebral bodies, in hospice.
She needed the medicine.
It was, of course, that's an obvious case, but so that was the only thing going in and going out, just like don't underprescribe opioids in this state. That was 2006. You remember? Did they do that for you? You don't remember that one.
I would have remembered that.
You would,
and that
but-
did not happen.
yeah.
That was a few years later.
Isn't that amazing? though? That's just mind blowing. And now here we are.
Oh my goodness.
And so, all right. So let's just. I think just remember about opioids. Opioids are endogenous. We have our own. There's a reason we have this system. It's not just, some exogenous structure to, kind of ruin our public health. Your own endogenous opioid system serves its own purpose, and we have endogenous opioids. That's endorphin on top, and that's morphine down below. There are opioid receptors distributed throughout your CNS and peripheral nervous system. The mu receptor in particular is the one that causes the most analgesia and euphoria. Kappa receptor to a lesser degree. Is that important? Probably not. I just put this on there just to remember that opioids have varying degrees of potency. There are some that are even far more potent than fentanyl, and the WHO has this analgesic ladder. So you don't start with hydromorphone.
Yeah.
You kind of go up it and then you go down it. Now, it's worthwhile to point that just some very recent studies have shown that opioids have essentially, not only are they not effective for chronic pain, which we all know, they make things worse. So you're actually going to be in more pain 6 months from now if you go on them.
Yeah, people say, well, it's just a Band-Aid or something like that, and I think, no, if you kind of smear germs all over a Band-Aid and put it on something, it actually makes it's not just that it doesn't even help, it makes it worse.
It makes it worse.
Yeah.
It makes it worse. All right. So what does opioid toxicity looks like? Constipation, meiosis, so their pupils get small, in contrast when they are withdrawing, where their pupils get blown. They can have respiratory failure, unresponsiveness. Treatment is, acute therapy is naloxone. You will induce acute withdrawal though, so that's only done in emergency situations. And chronically, oral naltrexone can help opioid dependency. Moving on from other peptides to orexin, just real briefly, orexin is a very potent stimulant. We talk about this at other times in brain pods. We talked about it in the differential of seizures. We talked about it during sleep, so we won't go into great detail there. I brought this in because orexin is also very important in psychiatry and eating disorders.
Yeah, it's related, but we don't yet know how to manipulate it.
We don't know how to manipulate it, and we also don't understand how they come together. So orexin, the orexin is the same molecule as hypocretin. Sleep people discovered it and called it hypocretin, and eating disorder people discovered it almost simultaneously and called it orexin, because it was lost in individuals with severe anorexia nervosa. And it makes sense that you would have a neurotransmitter that both wakes you up as well as promotes food searching behavior, right? So you lose it in conditions like narcolepsy as well as in anorexia. So that's the way I kind of put those together. And so it's very activating. It's nearly silent during sleep.
And we've tried to sort of use orexin therapeutically as an agent, and it doesn't quite.
It doesn't do it. How about any are there any orexin agonists that you're familiar with?
I think that's been explored, but sort of disappointing. Almost like the Alzheimer's treatment, where we say, hey, if we understand this mechanism, this should work, and then it doesn't quite, or there's limitations.
My understanding is it's a tiny little peptide, and I think tiny little peptides have a hard time getting from here past the liver through the blood-brain barrier intact.
Makes sense.
So. And for example, I mean, we would also love an orexin agonist for narcolepsy too, but we don't have that. We have an orexin antagonist, which I'll get to very briefly in a second. So narcolepsy results in sleepiness as well as cataplexy, which is the sudden intrusion of REM paralysis into wakefulness. I love this is an amazing video. This is a sister. There's a girl here who has cataplexy and narcolepsy. and this is her sister, and they're playing, and sister is tickling patient, and so induces this sudden paralysis. And it's, when you see it, it's hard to recognize it when you see it. Oh, I'm sorry. So my apologies. The video is not ready, but it's actually on, it's on the brain pods on sleep, so you can watch it. You can watch it there, as is there's an animal model. Finally, there is an antagonist for orexin. So here you have this neurotransmitter that is a stimulant. And so if you block it, you would make sense that you could become sleepier. So essentially what we're doing is we're inducing narcolepsy for the night. It's called suvorexant. It's been approved. Side effects, concerning side effects for it include morning sedation, concerns about motor vehicle accidents in the morning. I've had a few patients where we've tried to prescribe it. Best therapy for insomnia, by the way, is cognitive behavioral therapy for insomnia, hands down. That being said, on the rare occasions where we've tried it, I've never been able to get insurance pay for it. So
it suppresses appetite as well.
You'd think so, yeah. I mean, I don't know to what effect, and I assume somebody has probably tried using it for binge eating and obesity. I don't know the data.
It's being explored.
It's being explored. There you go. Finally, that's it. That was our neurobiology and neuropharm review. Next up is going to be myself with a very special guest, Dr. Starks, is going to be reviewing consciousness and coma. Dr. Nelson, thank you very much.
You're welcome. This was fun.
Yeah. In case anybody's been wondering, I've been holding the White Knight from Game of Thrones. There's others of these hidden in the shelving behind me on some of my other talks if you're too bored to listen to what I'm saying.
Will that be tested on? Which character was
never
in
know.
which video?
Never.
Yeah.
Well, one of them is going to end up on the final. They told me who is going to finally end up on the throne at the end of season 8 next year. All right, Dr. Nelson, tell us where will students get to meet you on clerkships and rotations?
Yes, I'm vice chair for education here at the Department of Psychiatry. So when you come through your psychiatry clerkship, you either just did that or you're headed there, and so you'll meet me when you come through, or if you do any electives in psychiatry.
And I do appreciate the fact that we do neurology and psychiatry right together. It's worthwhile to point out that I can't come up with a definition that distinguishes neurology from psychiatry. There's a historical difference, but we all know this is based on abnormal neurotransmitters or wiring.
Yep.
Just a different approach to it. And so yeah, I try to use the term clinical neurosciences because I think that describes what we do quite well.
Agreed.
Right.
Thank you.
Thank you very much.